Today we are going to delve into the world of neurology. Our topic of discussion is muscle paralysis or the muscle weakness. As you know that this is a very extensive topic and it is not possible to convey all the information regarding the muscle paralysis or the weakness in one complete lecture. So this lecture is going to be an overview and it will give you an outline of how we are going to approach someone with muscle weakness or muscle paralysis. We're going to discuss the various types and differentiating points among, for example, like the upper motor neuron lesion or a lower motor neuron lesion. And then afterwards, in the latter part of the lecture, we are going to see, with the help of various investigations, how do we, in a stepwise manner, approach a patient with muscle paralysis. To start off, let's define certain terms. Muscle paralysis is by definition a reduction in the power or strength of one or more muscles. Now, this can involve a group of muscles as well or a single muscle. There are certain other terms which are related to the muscle paralysis, and they are basically demarcated on the basis of the intensity of the problem. For example, you must be familiar with the term muscle paresis. Paresis is the term which signifies muscle weakness, but it is a milder muscle weakness as compared to a generalized paralysis. And on the other hand, on the other spectrum, we have a term which is called plegia. For example, paraplegia or quadriplegia. Plegia means a complete absence of the muscle power, a complete inability of the muscle to contract. So in terms of the quantification of the loss, we can say muscle paresis is a slight muscle weakness. Then we have muscle paralysis, which is the weakness of the muscle. And then if we have complete absence of contraction and complete weakness, that is termed as plegia or paraplegia or quadriplegia, as we are going to see in the coming lectures. So this is important to have familiarity with these terms because we are going to be using these terms interchangeably in the coming slides. Now, as we know, there are two types of major muscle weakness, either an upper motor neuron weakness or a lower motor neuron weakness. Let's discuss the upper motor neurons first. By the upper motor neurons, we mean that the neurons present in the brain or the brain cortex. These are the ones which send out the signals with the help of various tracts, and these are termed as the upper motor neurons. And the demarcation of the upper motor neuron can extend up to high cervical cord. So any nerve which is originating from the brain, for example, the premotor cortex or the motor cortex, and if there is a problem at the level of the brain or during any path of that track, then we signify that as an upper motor neuron weakness. Let us look at with the help of a schematic. This is the brain. Here we have a topographic representation of the various areas that are represented in the brain. If we look at this, then immediately we have the lower part of the body, like the hips, knees, ankles, and toes. You can imagine this topographic representation as someone who is standing and is bent forwards with his legs in the medial part and his upper body in the lateral part, and he's extending his arms or his fingers. So in the medial part, we have the representation from the hips, knees, ankles, and toes. And these are the areas which are affected if we have a problem with the anterior cerebral artery, because as we know that the anterior cerebral artery supplies the medial part of the brain, the medial part of the cerebral hemispheres. As we extend laterally, we have the trunk, shoulder, elbow, wrist, fingers, thumb, neck in a topographic representation, extending all the way up to the lips, the tongues, and the larynx. Now, the area of representation is different for different parts. For example, and the body parts which are concerned with very sensitive programming or sensitive execution of tasks, for example, are fingers, which are destined for some acute activity or very sensitive activity. They have a large representation. Our tongue has a large representation. Our larynx has a large representation. Our eyelids have a large representation. While certain other parts like the trunk and the shoulder, they are not represented in a very large area or a very large topographic representation. So it is important to be familiar with this topographic representation, because based on the type of the lesion or the area of the lesion, we can signify, or based on the type of the muscle weakness or whether the weakness is in the upper body or in the lower part, we can cater it down to the area of the brain that is affected. So here we are going to represent various tracts which originate from the brain or the cerebral hemispheres. The major one are the corticospinal tracts. These are the major ones that signify the upper motor neurons. The corticospinal tracts, as the name signifies, they start from the cortical area and extend all the way up to the spinal cord here. And these are the major ones that control the power of the muscle or the strength of the muscle. They start from the cortex, either the premotor cortex or the motor cortex. Then they pass through the posterior limb of the internal capsule, they pass through the pons, and at the level of the medulla, they undergo what is termed as a great medullary decussation. Decussation means that until the medulla, they travel ipsilaterally in the same part of, in the same area of the brain. And then at the level of the medulla, they decussate and move towards the opposite side. And then they transform themselves into the lateral corticospinal tract. And here in the lower part, at the level of the spinal cord, you can see if this is the lateral corticospinal tract, it makes connections with the anterior horn cells. The anterior horn cells basically signify the lower motor neurons. So we can clearly demarcate the upper motor neurons from the lower motor neurons. Upper motor neurons are the ones which are present in the cerebral hemispheres or the cerebrum. And the lower motor neurons are the ones which are present in the anterior horn cells of the spinal cord, and also the various types of spinal nerves which arise from the brain stem, like the 6th or 7th cranial nerve. The various cranial nerves, they also signify the lower motor neurons. So generally the upper motor neurons have an inhibitory effect. They tone down the activity of the lower motor neurons, and they have a control over the lower motor neuron activity. This corticospinal tract is also termed as generally the pyramidal tract. Now, there are certain other types of tracts which originate from the areas of the brain outside of the primary cortex, which are termed as the extrapyramidal tract. They generally evolve from the area of the brainstem or certain part in the high cervical cord. What are those various types? Let's look at them. There is an area in the brainstem region called the red nucleus, which gives rise to the rubrospinal tracts. Then there are reticular nuclei, which control the activation of our body. Various types of activities are controlled by the reticular activation system. They give rise to certain tracts. Then we have the vestibule nuclei at the level of the cerebellum. They give rise to the various tracts. Let's look at the name of these tracts. The tracts which are originating from the vestibule nuclei, they are termed the vestibulospinal tracts. The reticulospinal tracts are the ones which originate from the reticular area, and rubrospinal tracts are the ones which originate from the red nuclei. Corticospinal tract generally controls the power of the muscle, and while these extrapyramidal tracts, they give us an idea of the tone and certain other activities, the stretch of the muscle or the various reflexes regarding this, the control of the muscle. So corticospinal tract is generally termed as the pyramidal tract, and these other areas of the brain which gives rise to these tracts, they are generally termed under a common term called extrapyramidal tract to demarcate them, because the functioning of both of these areas is different. So here we are showing at the lower part of the body, the lower part of the diagram, the lateral corticospinal tract, as I've shown that as I told you that they start, the first motor neuron is in the cerebral cortex. Then they start and move from the internal capsule at the level of the medulla. They decussate and transform into the lateral corticospinal tract. And then these lateral corticospinal tracts either directly innervate the anterior horn cells. The direct innervation is generally for those anterior horn cells that innervate the distal muscles, because they are concerned with the fine tuning and the fine activities. Or they can also innervate the anterior horn cells via interneurons. Like you have seen, there is an interneuron in between these two cells. So along with that, we have the rubrospinal tracts, which is originating here from the red nucleus, and they are involved in certain estimation of the strength or the toning or the activity of the muscle, stretch of the muscle. And apart from them, the vestibulospinal tract, which originated here from the vestibular nuclei, they are being representative here in the anterior part of the spinal cord, and they also control the tone and the strength and give a good feedback to the cerebellum according to the power of the muscle and the area of the body which is being innervated. So this was an overview of the upper motor neuron. As we know that, as I talked about in the upper motor neuron lesion, they have a generalized tonic inhibitory effect on the lower motor neuron. So whenever we have an upper motor neuron lesion, that inhibition is lost, and there is the term which is used is called disinhibition. So everything is basically exaggerated. Like there is hyperreflexia in the upper motor neuron lesion. There is hypertonia along with the muscle weakness. The tone of the muscle is increased. The reflexes are hyper or increased. Then we have an upgoing planters or a positive Babinski sign, which we call the positive Babinski sign in the upper motor neuron lesion. It is a classical hallmark of an upper motor neuron lesion. Then we have spasticity, in which there is, when we apply power to the motion, the muscle is muscle has some spasm and it does not move. And after the power is being increased, then it suddenly starts moving, which is basically called clasp knife rigidity. When you apply the power to the muscle and try to move the muscle, it does not move. But with the increasing strength to the power, it is just moves just like a knife is removed from the clasp. So it is a classic term which is used for an upper motor neuron lesion. Along with that, there is no muscle atrophy at the start, but with the passage of time, we have muscle atrophy because of disuse. So that is termed as a disuse atrophy. So these are certain important terms to remember, because then now we are going to discuss the lower motor neurons, and then we are going to differentiate the representation of the lower motor neuron weakness, and we are going to see what are the differences of the lower motor neurons from as compared to the upper motor neuron weakness. So let's go into what are the lower motor neurons. Lower motor neuron is a term which is basically used for either the anterior horn cells of the spinal cord or the spinal nerves nuclei. So these are the ones which are fall under the umbrella of this term. Whenever we have a problem at the level of the anterior horn cells or the nerves which are originating, which are termed as the lower motor nerves or the peripheral nerves, we term that as a lower motor neuron weakness. Now, for all these structures, the anterior horn cells of the spinal cord and the spinal nerves, and then the muscles they innervate, or the group of muscles, this whole area falls under a term which we call as a muscle unit. So any problem of the muscle unit is called a lower motor neuron problem. Here we are representing a lower motor neuron and a reflex activity, how the lower motor neurons generally work. Here you can see the alpha motor neurons and a gamma motor neurons. These are the efferent nerves which originate from these lower motor neurons and innervate the muscles. The alpha motor neuron is basically alpha is the major nerve which provides the contraction of the muscle, and gamma is the one which monitors the strength or the stretch of the muscle at the level of this spindle. We have the muscle spindles at the center. They give us a good indication via these afferent neurons this muscle stretch is being monitored by these afferent neurons, and it reaches to the anterior part of the spinal cord at the level of the anterior horns. And with the help of this feedback mechanism, we can see whether the muscle needs to contract, and if we need to contract the muscle, then we have activation of the alpha nerves. These alpha nerves stimulate this muscle via neuromuscular junction and lead to the muscle contraction, while gamma is the basic one which tones down, which is important as compared when in context of the muscle stretch or the toning. So let's just talk about a muscle reflex quickly here. What is a muscle reflex, or the reflex arc, as we see? As you have seen here, a muscle, and for example, you perform various muscle reflexes like the knee jerk or the jaw jerk. It is the same representation as I'm telling you here. What happens here is when, for example, if we, with the help of a hammer, we strike a hammer on the tendon of this muscle, then the muscle is stretched. This stretch is transmitted by the afferent neurons to this anterior part of the spinal cord. And with these anterior horn cells, they sense the stretching of the muscle, and then to counter that stretching, they activate or fire by these alpha and the gamma motor neurons. And with the help of alpha motor neurons, the muscle contracts or shortens. And this is the classical reflex which we have. For example, when you strike a patellar tendon with the help of a hammer, the leg moves or contracts or stretches. So this is what happens in a reflex arc. And what happens in a lower motor neuron weakness, if we have any problem or trouble in these anterior horn cells of the spinal cord, or at the level of these spinal nerves, or at the level of the muscle unit, there is a generalized weakness. Then contrary to hyperreflexia at the level of the upper motor neuron lesion, we have hyporeflexia, because the upper motor neurons are working fine here, and they are continuously inhibiting the lower motor neurons. The problem is at the level of the lower motor neurons. So we have hyporeflexia, hypotonia, decrease in the tone, a generalized weakness or a strength of the muscle. We have certain things which are called muscle fasciculations, which are certain twitches which are visible not to the naked eye, but we can see on the EMG representation. And then there is generalized atrophy of the muscle because of the inability of either the nerves to innervate, or either there's some problem at the level of the muscle. So as you can see that these are opposite things which happen in the lower motor neuron weakness as compared to the upper motor neuron weakness. So with the help of these clinical signs, we are very easily able to differentiate an upper motor neuron lesion from a lower motor neuron lesion. These are certain important things to have a background of what is an upper motor neuron weakness, what are the basic various classic signs and symptoms, and what is the lower motor neuron weakness. Now let's move forward and see what happens at the level of the next muscles. For example, apart from these upper and the lower motor neuron lesion, we have certain weakness at the level of the neuromuscular junction. What is a neuromuscular junction? It is basically a junction at the level of the muscle between a nerve and the muscle. This blue area is being represented by representing a nerve, a spinal nerve, and this area is being shown here, which represents a muscle. Now there are various receptors here. These round structures which are present inside the nerve plate are the acetylcholine. With the help of certain receptors, when calcium moves inside the cells, it leads to exocytosis of these acetylcholine vesicles. These vesicles move out, and then they are basically innervate all these receptors present here at the level of the muscle. And when this acetylcholine is coupled with these receptors, there is generalized depolarization of this skeletal muscle. And when that depolarization reaches a threshold, that action potential reaches a threshold, then an action potential is generated and the muscle starts to contract. So this is a generalized overview of what happens at the level of the neuromuscular junction. Now, what happens in certain diseases? For example, here myasthenia gravis. Myasthenia gravis is a problem in which we have an autoimmune problem in which we have antibodies to these receptors which couple the acetylcholine. So whenever, as you are being shown here with the help of these red antibodies, whenever we have the receptors, antibodies to the receptor, then these compete with the acetylcholine for the binding to the receptor. So if the extent of these antibodies is very high, then they can completely cover all the receptors, and we have nowhere for the acetylcholine to bound, and then it leads to a generalized muscle weakness. And this is generally termed as a stepwise weakness because it generally happens late in the evening when the muscle has been used for a long time, and it happens. It is pretty much evident in in the muscles which execute very fine activities like your ocular muscles or your swallowing muscles or your finger muscles. So the person will present with classical representation of myasthenia gravis is a person who presents with, who is fine in the morning, and when as the day progresses and he uses all his muscles, then at the latter part of the day or during the evening, he feels a lot of weakness or fatigue, especially at the level of the ocular muscles. He has difficulty in the swallowing process. He has difficulty in performing fine activities with the help of his hands. So the distal muscles are the ones which are majorly affected. Now let's talk about certain pathologies at the level of the muscle. We are moving in a stepwise manner. We started off with the nerve problems, upper motor neuron or a lower motor neuron lesion. Then from the nerves, we move to the neuromuscular junction issues, for example, like myasthenia gravis in the previous slide. Now, what can go wrong at the level of the muscle, which we had termed as the myopathies? There are various types of myopathic weaknesses, like muscular dystrophies. For example, Duchenne muscular dystrophy is one type of muscular dystrophy in which there is abnormal types of musculature, or inflammatory issues which are termed in the inflammatory myopathies, or there are certain myopathies in which we have the muscle fiber necrosis. These are the major terms which fall under the umbrella of myopathic weaknesses. All of these lead to number of the muscle fibers reduction. There is the number of muscle fibers which are available for contraction, or the power, they get reduced either through inflammation or through necrosis or through dystrophies, and then eventually it leads to a loss of the contractile force. So at the level of the muscle, there are a lot of terms which fall under the umbrella of inflammatory myopathies or the myopathies in which muscle fiber necrosis. There are a lot of drugs that can cause these myopathies. For example, statin-induced myopathy is very much known. Certain glucocorticoids or steroids can cause myopathies over a long-term usage. So this is an overview of a myopathic weakness. Then there is also some psychogenic weakness, which is basically a weakness which does not fall. It is a diagnosis of exclusion, and it is a muscular weakness which does not fall under other categories, either in the nerve problem or neuromuscular problem or a muscular problem. Psychogenic weakness is very common and it is basically related to certain psychiatric issues. For example, there are certain terms which are used as somatization disorder, in which there is a classic weakness of a certain particular muscle or an area of the body, but which is not localized to certain part of the brain, and it is also associated with certain anxiety or depressive symptoms, signs and symptoms. So psychogenic weakness is someone which is basically seen by someone who presents with a generalized muscle weakness or fatigue or inability to move his arm suddenly, and the underlying mechanism is psychiatric or behavioral, and it does not point to an organic lesion. Here it is just showing in this diagram one sign in which signifies that the person might have psychogenic weakness is that when one muscle is moved or suddenly an arm is dropped from a height of a person, in this case a female, then there is movement of the other muscle or the contralateral muscle. This is not very evident or common in all types of psychogenic weakness, but this is a sign which can indicate that this patient might be having certain psychogenic weaknesses. Usually there is a very clear-cut history of anxiety or depression or certain stressful acute stress that can lead to all these problems. For example, in somatization disorder, there is or somatoform disorder, there is anxiety or depression which manifests as physical symptoms, and the patient might have inability to move his arm, and you might be thinking that this might be an upper neuron lesion or a stroke, and then you do the investigation, the CT and MRI, and everything is clear, and there is no organic lesion to point out, then you classify or term it as a psychiatric problem or a somatization disorder, and you perform a thorough MMSE, mental state examination, to look at the various stressors involved and try to relieve it. And it usually goes away with the relief of the stress or the relief of the psychiatric issue, which is the underlying core problem. So it basically is a psychiatric problem presenting in an organic way or a functional problem. Now, these were the various types of muscle weaknesses. Now let's look at the certain presentations and how these presentations give us clinical clues to point out the area of the nervous system that is being affected. Hemiparesis is basically, hemi means half and paresis is the muscle weakness. So weakness of the half of the body or the one part of the body. For example, here it is demarcated that if someone has a weakness of the left side, upper limb and the lower limb, then and the right side is perfectly fine, then that is classical for hemiparesis. And hemiparesis is basically a sign of an upper motor neuron lesion or a cortical lesion. With the help of the area affected, we can point it out particularly to what part of the brain is affected, for example, and the magnitude of the area which is being affected. For example, if arm is affected more than the leg, then we can have a good idea that it might be some lateral part of the hemisphere that is being affected with some involvement of the medial part. And conversely, if the leg is being more affected than the arm, then this might have some anterior cerebral artery problem with the legs being affected, and it might extend to certain cerebral hemisphere. So whenever we have a patient with hemiparesis, we generally do a CT scan to look at some ischemic or a blood, whether there's certain ischemic lesion or a bleed into the brain, and generally it is an upper motor neuron lesion. And with the help of the other signs and symptoms, for example, certain problems with the spinal, certain problem with the cranial nerve or the nuclei, if we have signs of the cranial nerve nuclei as well, then we can pinpoint this to what part of the brain which is being affected. Let's look at a few causes of these hemiparesis and what are the various clues we get along with this hemiparesis to pinpoint the lesion in the upper motor neuron. If along with the hemiparesis we have certain language disorder, then the area of the brain which is affected is the cortex and primarily the Broca's area or the speech area. is being affected, which is part of the parietal lobe, and we can pinpoint it to the part of the brain. Similarly, if along with the hemiparesis we have a homonymous visual field defect, then we know that this is some involvement of the optic chiasma or the subcortical hemisphere lesion, and might also have some pituitary signs and symptoms with it. If it is involving a pituitary, it might be a pituitary tumor, which is converging on the optic chiasma to give us this visual field defects. If we have a pure motor hemiparesis of the face, arm, and legs, then we know that this is a small discrete lesion in the posterior limb of the internal capsule, because internal capsule is the part of the brain which exclusively contains the motor fibers. The motor fibers, the corticospinal fibers, they start from the motor cortex and then move from the posterior limb of the internal capsule and all the way through the cerebral peduncles to the upper cerebral pons. So a pure motor lesion of involving all the parts of the side, the face, the arms, and the legs, it gives us an indication of that this might be an infarct or a bleed in the posterior limb of the internal capsule. If we have an absence of the cranial nerve signs or the facial weakness, then we can pinpoint this to a lesion in the high cervical spinal cord. Whenever we have a cranial nerve sign or lesion, then that usually gives us a crossed presentation, which the contralateral side of the body being affected because of the corticospinal tract involvement, and then ipsilateral sides are affected with the help of the cranial nuclei. So if we have a crossed presentation with the cranial nerve nuclei signs at one side and corticospinal signs on the other side, then we know that we can pinpoint it out to the level of the brainstem, either the midbrain, pons, or medulla, and depending on the nerve involved or the signs and symptoms of the nerve involved, we can pinpoint it exclusively to what part of the brainstem it is involving. Either it is from the midbrain or the pons or certain medullary signs. But if we have the absence of the cranial nerve signs or the facial weakness, then we can very confidently say that this might be in the high cervical spinal cord lesion. If we have the presentation of hemiparesis very acutely or episodic, then this might be a focal structural lesion, or very small area of the brain might be affected that has given to this episodic or an acute problem. Like if we have an interruption of the blood supply to some small artery supplying one part of the brain, then we might have a weakness in that dermatome or in that area of the body, just for a focal point or an episodic point. If we have subacute hemiparesis generally occurs if we have certain bleeds into the brain, certain the bleeds which accumulate slowly over a period of days or weeks, like subdural hematoma or certain underlying infections or metastasis from the tumors from the other parts of the body. These generally have a subacute presentation, and they can have various presentations depending on the area of the brain they are being targeting. In patients with HIV or AIDS, they have subacute hemiparesis generally, and the two important neurological problems in AIDS patients are toxoplasmosis and the primary CNS lymphoma. These are the various toxoplasmosis is the parasite which infects the brain and has various causes various calcifications in various parts of the primary motor cortex. And the CNS lymphoma is basically a tumor of the lymphoids, and it also presents subacutely in the form of subacute hemiparesis in long-standing AIDS patient or someone who has a very low CD4 count, and they have a full-blown disease of the AIDS which is not being controlled with the help of the medication. Then these infections of toxoplasma and a tumor like a CNS lymphoma that can present in these HIV positive patients or AIDS patients. And chronically, if someone who has hemiparesis which develops over a period of months, or a chronic or a very slow development, then that patient might have some underlying neoplasm or a vascular malformation, or a chronic subdural hematoma which bleeds very slowly over a period of time. It collects the blood and leads to focal neurological deficits over a period of months, or a certain degenerative disease which in the old age that can also present with chronic hemiparesis. So these are very important, or this basically covers everything related to hemiparesis. What are the major causes? And you can pinpoint the area of the brain being affected depending on the presentation, either depending on the various cranial nerves being affected, presence or absence of the cranial nerve signs, and whether the arm is involved more or the leg is involved more, and mathematically you can easily pinpoint the area of the brain. Then we do a CT scan of the brain or an MRI if it is needed to confirm our findings, and then evaluate the patient accordingly. Paraparesis or paraplegia is generally muscle weakness of the both lower legs. Paraplegia means weakness at the level of the legs. Quadriplegia, which we are going to see in the next slide, is when all the four limbs are being affected, with two arms and the two legs. That is called quadriplegia. But if the two legs are affected, then that term is the term which we use is called paraparesis or paraplegia. Paraparesis generally is a lower motor neuron problem. Depending on the level of the spinal cord, depending on the level at which the lesion of the spinal cord is, we have varied representations. And with the help of a neurological examination of the legs and concomitant motor and the sensory examination, we can very confidently pinpoint the lesion to the spinal cord. Now, what can cause paraparesis? Generally, paraparesis occurs in someone who has undergone certain trauma, or, for example, a road traffic accident, and his back has been compromised, or someone who has been hit very forcefully in the back during certain injury. So it's generally a trauma-related problem, or it can also present in the form of certain disc lesions. Slip disc can present, for example, sciatica can present, and then in long-standing, if the patient has muscle weakness, then that is because generally of certain disc herniation can present it. But the major one to remember here are the trauma or certain accidents where the patient presents with acute paraparesis or paraplegia. Similarly, if the patient presentation is subacute or chronic, then this might be a certain slow-growing tumor of the spinal cord or certain metastasis which move from the various other organs to the neoplasm mets, which then target the spinal cord. And then with the help of neurological examination, we are going to pinpoint the area and confirm our findings with the help of an MRI. An important disease to mention here is called GBS or Guillain-Barré syndrome. What happens in GBS or Guillain-Barré, we have an ascending infection. It is an autoimmune demyelinating disease which starts at the level of the legs and slowly moves upwards. So if we have a patient in which we have found out on neurological examination that the weakness started at the level of the feet, and now the patient has weakness at the level of the knees and it is ascending up, it is very important to rule out GBS or Guillain-Barré syndrome, especially if it is occurring after a viral infection or a viral gastroenteritis or someone who has been immunized, because something happens after this infection or an immunization that triggers the immune system, and it starts targeting the oligodendrocytes or the cells which make the myelin, and then it leads to demyelination of the nerves, especially at the level of the spinal cord, and then slowly it moves up. And it is very important to diagnose it early, because this ascending infection can also involve the diaphragm, and when the diaphragm is involved, the patient will have inability or difficulty to breathe, and then that can be lethal, and that can lead to mortality of the patient as well. Let's talk about quadriparesis or a generalized weakness. These two terms are being used interchangeably. Quadriparesis means, quadri means four. So if all the four limbs, the two arms and the two legs are affected, and the patient is unable to move any arm, then that term, the term which we use for that muscle weakness is quadriparesis. It is also termed as a generalized weakness. Most of the times it is an upper motor neuron problem, and it can involve, and generally it is a large area of the brain that is being affected, or it can involve the both cerebral hemispheres. But in certain in certain conditions, it can also be a lower motor neuron problem. And the differentiating points of the upper motor neuron and the lower motor neuron, like the evaluation of the reflexes, the tone and the strength, and the fasciculations or the Babinski sign, they are going to differentiate both whether it is an upper motor neuron or a lower motor neuron lesion. And along with that, the reflexes, we check the reflexes, and in the lower motor neuron lesion, the reflexes are generally compromised, and so that gives us a good indication. This somatosensory examination, the pain examination, these things give us a very good indication of of differentiating a lower motor neuron problem for a upper motor neuron lesion, because you know that if certain reflexes like defecation reflex or micturition reflex, these are also being affected along with the weakness, then it is more likely a problem at the level of the spinal cord rather than the brain. We classify it again on the basis of the timing of the presentation in acute, subacute, or the chronic forms. We are going to look at the certain causes in the next slide. Acute is again in certain acute presentation of quadriparesis, maybe in someone who has had very high bleed in the brain or a very acute stroke. That cerebrovascular insufficiency, he can present acutely, or in someone who has had a very rapid electrolyte issue, he can present with generalized weakness as well, as we talked about this in the hypernatremia and the hyponatremia section. The muscular problems generally are related to the potassium disorder. So if someone has hypokalemia or hyperkalemia, then they can acutely present with a generalized weakness or a quadriparesis. So along with the examination of the nervous system, it is very important to look at the labs and an overall picture of whether the patient has what is the sensorium of the patient, what is the GCS, whether the patient is conscious and is talking coherently, and all these factors have to be taken into account to arrive at a diagnosis. Subacute presentation or a chronic presentation can be because of a slow growing tumor or slow growing mets, or subdural hematomas, which is a long-standing hematoma or involving a very large area of the brain if it involves both hemispheres, or certain hydrocephalus conditions that can pressurize the brain cavity. So these are certain infections like viral encephalitis. It can also present as a generalized weakness, and then patient will also have altered sensorium as well. So if someone who presents with a generalized weakness and has altered sensorium, then it clinically rules out a lower motor neuron problem, and then you have to either look at whether it is a problem involving the brain, either it is a structural lesion of the brain, or whether it is any metabolic disturbance like a sodium abnormality that can lead to this altered sensorium or delirium or confusion in these patients. Let's look at a few causes of the quadriparesis. Number one, as I talked about the electrolyte disturbances, specifically the sodium. Remember, sodium abnormalities present with problems with the brain or the nervous system, and the potassium abnormalities, as we talked about, and potassium along with the magnesium. Potassium and magnesium go hand in hand, and these abnormalities present with muscular weakness or the sensorium is intact. It can be a muscle disorder, which can involve the generalized muscle, for example, a GBS, which is starting from the lower legs and moving upwards. If it involves arms as well, then that is a problem. It can be a myasthenia problem at the level of the neuromuscular junction. It can be a channelopathies, for example, problem with the ion channels like the potassium channels, or certain metabolic defects of the muscle, for example, certain enzyme deficiencies that can present with muscle weaknesses. It can be a glycogen storage problem. Certain other lysosomal disorders can present like this. Neuromuscular junction disorders, the two most important ones to remember are the myasthenia gravis. We talked about it in a previous slide. And another one which is related to the neuromuscular junction is the Lambert-Eaton myasthenic syndrome. Now, in myasthenia gravis, as I talked about, it is an autoimmune problem in which we have antibodies against the receptors of the acetylcholine receptors antibodies. In Lambert-Eaton myasthenic syndrome, we have antibodies against the calcium channels. These calcium channels are present in the presynaptic nerve terminals, and when these calcium channels open, calcium moves into the presynaptic terminals and it leads to expulsion or exocytosis of the acetylcholine vesicles. So these channels are very important for the exocytosis or the movement of the potassium or the release of the release of the acetylcholine from the nerve terminals to the muscle or at the level of the neuromuscular junction. So anything that targets these calcium channels will lead to an inability of the acetylcholine production. So Lambert-Eaton myasthenic syndrome, generally it is a paraneoplastic syndrome, and most common carcinoma which causes a Lambert-Eaton myasthenic syndrome or leads to the production of the antibodies against the presynaptic calcium channels is the small cell lung cancer. And we diagnose it as myasthenia. I told you that this is basically a fine muscle weakness or a smaller muscle weakness, like the ocular muscles are involved or the hand muscles are involved or the pharyngeal muscles are generally involved, and it occurs at the latter part of the day when you have used the muscles over a period of the day. Lambert-Eaton myasthenic syndrome, on the other hand, is a complete opposite of what happens in myasthenia. It generally involves the muscle groups which are not used very much, like the proximal muscles or the shoulder muscles or the leg girdle muscles, large muscle groups, And it occurs at the start of the day or the early morning, when, as you know, that the acetylcholine is unable to being produced because of no calcium influx. So the person tries to contract the muscle and he's unable to contract. But when he tries to repeatedly contract it, then over a period of time, there is some acetylcholine release, and that can lead to production movement of the muscle. So in myasthenia, when we look at the EEG or the EMG, sorry, then we have a increased power and it slowly tapers down. And in Lambert-Eaton syndrome, we have a slow or a flat line at the start, and it slowly gives to contraction of the muscle. So it is important to differentiate both of them clinically, because whenever we have someone with Lambert-Eaton syndrome, it is very important to look at the chest, either with the help of a CT scan, to find what is causing this Lambert-Eaton syndrome. So you might diagnose someone with small cell carcinoma just because of the presentation of Lambert-Eaton myasthenic syndrome. Certain central nervous system disorders like stroke or transient ischemic attack of the brainstem, or transient global cerebral ischemia. If it is a global ischemia, then the patient might present to you with syncope or dizziness. Multiple sclerosis can affect anything from the central nervous system to the spinal cord. It is also a demyelinating disorder. As you know, we are going to talk about multiple sclerosis in a separate lecture on that, on multiple sclerosis. But you know that whenever we have neurological symptoms separated in time and space, which do not confer to one area of the brain, then that, especially in a young female, then that raises suspicion of the multiple sclerosis. It is an autoimmune demyelinating disease, and the classical way to diagnose it is to do with the help of an MRI. We have paraventricular calcifications, and it is a difficult disease to treat, and we have a relapsing remitting disorder in which the patient presents with one sign, and then over a period after some relapse they present with another sign, and then we have to treat them with high dose steroids. We're going to talk about it in a separate lecture, but just remember that multiple sclerosis can also present as a generalized weakness or quadriparesis. And if we have no organic lesion at the level of the brain or the spinal cord, and the electrolytes are fine, and there are no much, the EMG is also working fine, then we have to look at the psychiatric side of things, whether the patient has certain anxiety issues, or the patient might be depressed. It might be a presentation of a somatoform disorder, just as we talked about in the psychogenic weakness. And this is very common in our practice. Psychiatric disorders are becoming rampant because of increasing incidence of anxiety and depression. And someone might present to a neurologist or a medical specialist with generalized muscle weakness, and you suspect that this might be some neurological issue or an electrolyte abnormality, and you do all the investigation and you can't find out anything. Then after a very close or a very well monitored MMSE or a multiple mental state examination, you seem to uncover this underlying psychiatric vulnerability that is leading to this organic or a functional problem. Somatization disorder is basically the term which we use for the functional representation or an organic representation of a psychiatric disorder. This gives us a very good overview or what are the various things that can cause quadriparesis or a generalized weakness. Now let's look at certain terms which are related to the weakness. Monoparesis, mono means one is when there is weakness related to one part of the body. For example, if just your arm or the medial side of the arm is involved, then that is termed as monoparesis. What can cause monoparesis? Generally, it is you can classify, you can think of monoparesis as a certain one nerve injury. For example, if there is a brachial plexus lesion at the level of the elbow, or someone who has been hit in the elbow or medial condyle fracture of the elbow, he might present with ulnar nerve problem. That is a monoparesis in which just one nerve is involved. If someone who is falling and he holds on to a tree or a bark, then that can lead to monoparesis or one nerve injury. So monoparesis is basically, or someone who has been in a cast, it can lead to weakness or the nerve injury at the level of the arm after a few weeks. So monoparesis generally is one area of the body that is being affected, and it is generally a localized problem up to that level. Similarly, we have a distal weakness, or classical representation for this weakness is a term which we use, which is called a gloves and stocking appearance. The gloves in this term means the arms, and the stockings means the legs. This distal weakness or gloves and stocking weakness, generally it can be a sign of an upper motor neuron lesion, specifically affecting the spinal cord at the level of the areas which has control the distal muscles, and at the level of the brain, the lateral parts which control or the fine movements. It can also be a representation of an organic problem like diabetes mellitus, which leads to a neuropathic and classically presents with a distal weakness or a gloves and stocking appearance. Similarly, a lot of other metabolic conditions, a lot of other neuropathic problems, any neuropathic injury at the level of the spinal cord can also present with distal weakness or a gloves and stocking appearance. So whenever we have this, then we have to investigate and look at the somatosensory associated problems. Either it is a pure motor problem, or whether we have certain pain or paresthesias also, and then that can help to pinpoint the lesion either at the level of the spinal cord or at the level of the brain. And also we do the electrolyte calculations, and also the BSR, and monitor the diabetes in case of the patients, or the uremia in someone with CRF or chronic renal failure, because these can also present with neuropathic problems like these gloves and stocking or a distal weakness. Proximal weakness, which involves generally the proximal muscles, the shoulder muscles, or the pelvic girdle muscles. It is basically a sign of a lower motor problem, most likely, and it can also be a sign of certain organic problems. Specifically, certain drug-induced proximal weaknesses are very common, like statin-induced myopathy. It involves the proximal muscles. I told you the Lambert-Eaton syndrome at the level of the neuromuscular junction. It can involve the proximal muscle. Corticosteroids-induced myopathy can involve proximal muscles. And generally, proximal muscle weakness can also be a sign of certain myopathies. For example, Duchenne muscular dystrophy presents with the pelvic muscle problem. Other inflammatory myopathies or myopathies with muscle necrosis, these generally give rise to the proximal weakness. So we do a good neurological examination to pinpoint the problems and to localize it, whether it's at the level of the spinal cord or the brain. If we can't find anything, then we look at the drug history of the patient. We do a various inflammatory examination, the ESR of the patient, or certain other labs to look out whether it is a manifestation of certain underlying muscular problem. We can do the CPK or the CK or the aldolase count, which gives us a good indication of the level of the problem, if it is at whether it is an inflammatory problem at the level of the muscle. And if we have a weakness in a restricted distribution, just like a monoparesis, then the area which is affected gives, or the dermatome affected gives us a good indication of the part of the central nervous system which is being affected. For example, there might be certain extraocular muscle weakness, and that might give us an idea of the cranial nerves which innervate the extraocular muscles. The superior oblique muscle, for example, is innervated by the fourth cranial nerve. If that nerve is affected, then the superior oblique can not work properly, and then we have classical signs and symptoms related to that cranial nerve. Similarly, a hemifacial problem, if it is a facial nerve weakness at the level of the lower motor neuron, it presents with a hemifacial problem. We have the bulbar or the pseudobulbar problems. The respiratory muscles might be affected if we have certain problem with the diaphragm. For example, the phrenic nerve is affected. So these are restricted distributions. One part of the body is affected, and that gives us a good indication of a clinical clue to how to look for the area of either the spinal cord, the cranial nerve, or the brain stem, or the cortex, primary motor or the secondary motor cortex. Which area is, when we look at the investigations or clinically do clinical examination, what is the area which we are going to focus. Now, let's look at a few causes of weakness in a restricted distribution. A lower motor neuron or a peripheral nerve disease can cause it. It can also be caused by a myopathy or a neuromuscular junction disorder. When we have a myopathic or an NMJ or a neuromuscular problem, then it is a relatively symmetric weakness of extraocular or bulbar muscles. For example, in myasthenia gravis, there is an extraocular muscle weakness which is symmetric, involves both sides, both eyes. GBS, as I talked about, it can lead to an ascending infection, and it can also affect, eventually involve the diaphragm, and it can also affect the facial nerve. And whenever GBS infects the facial nerve. It is a bilateral facial palsy with areflexia. There is a loss of the reflexes, and the facial nerve is affected on the both sides. So it's a classical sign. There are very few conditions that can give rise to bilateral facial palsy. One important one to remember is the GBS or the Guillain-Barré syndrome. The other one, especially in the United States, is and in certain states like Connecticut, etc., are the Lyme disease, which is very much prevalent there. So Lyme disease and GBS or the Guillain-Barré syndrome are the conditions which present with bilateral facial paralysis. These are the major ones. Certain neuromuscular junction disorders, and for example, in myasthenia, there are worsening of the relatively symmetric weakness with fatigue over a period of the day. The opposite happens in Lambert-Eaton myasthenic syndrome, in which there is weakness at the start of the day and it eventually goes on to improve after the repetitive action or the repetitive contractions. Motor neuron diseases can present as asymmetric bulbar weakness. Then along with that, if we collect or classify them collectively, the motor neuron disease, myasthenia gravis, or certain myopathies like the poliomyositis or dermatomyositis, they can also, all of these can eventually affect the respiratory muscles. So whenever we have the respiratory muscles or diaphragm problem, apart from the phrenic nerve examination, we also have to look at whether it is a certain underlying motor neuron problem. Myasthenia gravis can also eventually involve the respiratory muscles, and the poliomyositis or dermatomyositis, which are the inflammatory myopathies. These, apart from infecting various other muscles, can also affect the respiratory muscles. So it is very important to look at the patient on the whole in a good clinical context, to look at what is happening along with the muscle weakness, whether there are signs and symptoms of the upper motor neuron problem or the lower motor neuron problems, whether we have certain neuromuscular disorders with the weakness improving as the day passes or increasing as the day passes, and whether we have certain inflammation along with the myopathies. The labs of the ESR or the CK or the aldolase, they are being affected, to look at the overall context to arrive at a clinical diagnosis. Then after we have done our clinical examination and a good history, then how do we work up a patient with weakness? This flowchart might seem very confusing at start, but this is very easy to understand. Just remember two things. Whenever we have certain upper motor neuron problem or a cerebral problem, the go-to investigation is either a brain CT or an MRI. And if we suspect that we have certain problem of the spinal cord, along with that, for example, in a high cervical cord problem, then we can look at the spinal MRI. And if it is a lower motor neuron problem, then we can look at the spinal MRI as well. So lower motor neuron lesion, just think of the spinal MRI. Upper motor neuron lesion, think of a brain CT or an MRI. And along with that, we can do an EMG and nerve conduction studies as well to find out myopathic problems or certain problems which present with a lower motor neuron pattern. Let's look at this in a stepwise manner, and this will also provide us a chance to just revise what we talked about in this lecture. If the distribution of weakness is in a hemiparesis, or one half of the body is affected, then I told you that it is more likely a upper motor neuron lesion, and our go-to investigation is a brain CT or an MRI. If we are being faced with someone with paraparesis, in which both legs are being affected, then we clinically examine the patient and see whether we have upper motor neuron signs in this patient or a lower motor neuron signs. If we have upper motor neuron signs, then we look at the cerebral signs. Cerebral signs, for example, hyperreflexia, hypertonia. Along with that, we can have certain language disorders as well, if the lateral part of the brain is affected. If we have those signs, then again, we do a brain CT or an MRI. If there are absence of the cerebral signs, then you do a spinal MRI, specifically high cervical spinal cord MRI, to look for these upper motor neuron signs. If the paraparesis is accompanied by the lower motor neuron signs like the hyporeflexia, the atrophy, the muscle fasciculations, then along with that, then the first step to do is to evaluate with the help of an EMG or electromyography and the nerve conduction studies. We do an EMG and the nerve conduction studies, and then afterwards, we look at what is the pattern, whether it is a lower motor neuron pattern, then it might be an anterior horn disease or a peripheral nerve disease. If on EMG and nerve conduction studies, we concomitantly find that it is a myopathic pattern, then this might be a muscle or a neuromuscular junction problem. Similarly, if someone presents with quadriparesis or the four limbs are being affected, then you check their consciousness or GCS or their alertness. If they are alert, then that generally means that the sensorium is intact. Then you afterwards evaluate these patients again on the basis of the upper motor neuron and the lower motor neuron signs. If the upper motor neuron signs are present, then you do a spinal MRI, because alertness can rule out a brain problem, and you should look at the high cervical cord for certain problems. And if we have lower motor neuron signs, then again the first step is to do an EMG and NCS, and then we evaluate it further. If the sensorium is not intact, then it generally means that the cerebral area is being affected, and then you can see that this arrow goes all the way to the brain CT or an MRI. We evaluate the patient with the help of a CT or an MRI. If there is a monoparesis, one area is being affected, whether it is an upper motor neuron signs are accompanied or a lower motor neuron signs. Upper motor neuron signs are present, you go all the way to the brain CT or MRI. If we have lower motor neuron signs on examination, you do an EMG and NCS. Every lower motor neuron sign, the first step to do is electromyography and nerve conduction studies. They can give you a very good indication of whether the problem is at the level of the anterior horns or the peripheral nerve, neuromuscular junction, or whether the muscle itself is being involved. If we have distal problems, then we directly go to the EMG and NCS, and we can afterwards look for the patterns. If we have again just a proximal presentation, we again do the electromyography, and in a restricted pattern distribution, again do an EMG and NCS. Based on the results of the EMG and NCS, if the EMG and nerve conduction studies are fine and the pattern it gives us an indication of the upper motor neuron problem, then we do a brain CT or MRI to find out whether it is at the cortex, or a spinal MRI, high spinal MRI at the level of the high cervical spinal cord to find out a high cervical spinal lesion. If the pattern is a classical lower motor neuron pattern with areflexia or hyporeflexia, then we have to evaluate whether it is an anterior horn problem or a peripheral nerve disease. Or if the pattern is generally myopathic and accompanied with some inflammatory changes, then generally it is a muscle problem. Or if along with that, in case of Lambert-Eaton syndrome, we have concomitant carcinoma, then it might be a Lambert-Eaton or neuromuscular junction problem. Or myasthenia gravis, if we have the autoimmune antibodies, or the MRI shows paraventricular calcifications. So this complicated flowchart gives us an idea of how we are going to proceed. The bottom line, or the take-home point here is, if we suspect an upper motor neuron lesion, the go-to investigation is a brain CT or an MRI, or a high spinal MRI at the level of the cervical spinal cord. If we suspect a lower motor neuron lesion, then the first thing to do is EMG, electromyography, or the nerve conduction studies. And then based on the results of those studies, we either classified either it is a lower motor neuron problem, or whether we have certain myopathic or a neuromuscular junction problem going on. So with that, we complete our lecture on this muscle paralysis. This was an overview of muscle paralysis. You're going to discuss the individual disease in the respective sections, and after learning more about the diseases, you will get a good overview and a good indication or a deeper knowledge about this muscle paralysis. I hope I am able to help you here with a good overview of the muscle paralysis, and I hope to see you in another lecture.